Good morning, welcome, thanks for coming. My name is Rodrigo Hasbun. I'm a professor at UT Health, and we'll be reviewing the economic impact of film array in meningitis and encephalitis. We're going to look at current lab tests that are used to diagnose meningitis and encephalitis, and then we're going to look at the rapid multiplex PCR and try to see how that could improve patient care. So this is a study that we did looking at bacterial meningitis in the United States between 1997 and 2010. It includes the three most common community-acquired meningitis pathogens: strep pneumo, H. flu, meningococcus, and also includes gram-negatives and Staph aureus, the two most common causes of nosocomial meningitis. And as you can see in the graph, there's been a decrease in the incidence of pneumococcal meningitis and meningococcal meningitis, especially after the introduction of the conjugate vaccines. Still, pneumococcal meningitis is the #1 pathogen in the United States, but you can clearly see that meningococcus, H. flu, their incidence approaches those of nosocomial meningitis pathogens in our hospitals. This is a large study that we just published last year looking at meningitis and encephalitis in the United States. And what we can see is that now that bacterial meningitis has really become less frequent with the conjugate vaccines, we can see that viral meningitis is the most important and frequent cause. Out of 24,000 patients with meningitis and encephalitis, you can see that enterovirus is the most common one. There's other herpes, fungal, bacterial meningitis accounts, for a small portion of the cases. And what we can see here is that antibiotic therapy is being used on the majority of all etiologies. So if you look at enterovirus, 89% of those patients are getting empiric antibiotic therapy, meanwhile trying to figure out if it's viral versus bacterial. Same thing with herpes, they're getting a lot of antibiotic therapy. Acyclovir therapy is given in 57% of our patients, when only a minority of them have herpes encephalitis. So we're using a lot of antibiotics and antivirals in etiologies that do not require them. So the first test that we always have is a gram stain, and if you have a positive gram stain, the dilemma is over. The patient has either bacterial meningitis or fungal cryptococcal meningitis. So here we have Neisseria meningitidis, strep pneumo, and H. flu, typical gram stains, and then we have cryptococcus. The problem is that the majority of the patients that come in with meningitis don't have a positive gram stain. 94% of our patients come in with a negative gram stain, and that makes physicians uneasy. You have a very broad differential diagnosis. There's some etiologies that need to be treated urgently in order for them to survive. There's a lot of immunosuppressed patients, and at the end of the day, the majority of our patients don't have an etiology. They go home without a diagnosis. So it's frustrating, and physicians tend to admit almost everybody that comes in with any meningitis to the hospital. And this is occurring not only in the U.S. but worldwide. This is an international study of 20 countries where 2,583 patients. You can see that 58% of the patients did not have a diagnosis. That is appalling, that more than half of the patients that come in with a brain infection, you cannot see the patient in the eye, tell them you have this is your prognosis, this is the treatment. They go home without knowing what happened to them. This is especially troublesome in aseptic meningitis. This is a very large study we did last year, over 500 patients. And what I wanted to show in this study is that we're using our current diagnostic techniques very limited. You can see that an HIV test was only done in 30% of our patients, adults. HSV PCR in adults, 39%. West Nile in a third of patients are being tested. Encephalitis PCR in adults, 15%. VCV, 1%. No wonder why 86% of our patients don't have a diagnosis when they go home. And those patients are being admitted, treated with antibiotic therapy, getting CAT scans that are useless. All the CAT scans are normal in aseptic meningitis, And the MRIs as well, they only show meningeal enhancement that really does not impact clinical care, and everybody does well. So it's a benign illness, and patients shouldn't be admitted like they are. They're all being admitted and image and antibiotic therapy, and it's for 4 days. They're being hospitalized for a long time. So knowing those problems, what are the solutions? Well, we would like to derive and validate clinical models that help physicians decide which patients could go home because they are low risk of having something treatable or something or a bad outcome happen to them. We want to really standardize the way we do diagnostics because right now it really depends on who's on service, who's the physician taking care of the patient, and how much CSF you have to determine which test you're going to order. And then we need to really explore novel molecular diagnostic techniques. So we've derived and validated 2 scores, one for less than 1% chance of having an adverse clinical outcome in 567 adults with meningitis and a negative gram stain if their age is less than 60, their neurological exam is normal, and their glucose is normal. And then we also have another model, a clinical model, finding a zero risk group in patients if they're immunocompetent, have a normal neuro exam, have a normal glucose, have a low protein, and have a low serum white count. All those parameters are easily available in the emergency room. And this last study was done in 960 patients, was derived in New Orleans, validated in Houston, and validated in the Amsterdam, in the Netherlands, and it was 100% sensitive. Are physicians using this? No, they're not. They're not using these models. They're still admitting patients right and left because they want a diagnosis. They want to know what the patient has in order to make a decision what to do with those patients. So you can see this just a comparison between New Orleans and Houston, different tests that are being done in patients with meningitis and a negative gram stain. The only thing that's really done in 100% of our patients almost is CSF bacterial cultures. The rest is really depends on the center, but you can see any PCR was done in less than 50% of the patients. An HIV test in this study, 2/3, serology for West Nile and 1/3. So it's really, we're underutilizing the current available techniques. In this study of 750 patients in Houston, both adults and kids with meningitis and encephalitis, we can see that West Nile serologies are being done throughout the year. Throughout the year, you can see here. And the white boxes are positive cases. So you can see that West Nile only occurs between June and October. And between June and October, only 37% of our patients are getting tested for West Nile. And none of the patients between November and May had West Nile. So we should not even be checking West Nile serologies when there's no West Nile in our country, in our endemic areas. And we should be checking for West Nile on all patients that come in when it's endemic. So right now, especially right now, we should be checking on everybody. If you look at costs of taking care of patients with bacterial meningitis, again, this is from our study looking at the trends. From 1997 to 2010, you can clearly see there's been an increase in cost. So pneumococcal meningitis cost $37,000 in 97, now it's $82,000. So in 2010, you can see pneumococcal gram-negative because a lot of those patients are nosocomial meningitis and they're very sick and they're in the ICU with craniotomies. Staph aureus, also $86,000. So the cost of taking care of bacterial meningitis is around $80,000 to $100,000 per hospital admission. That's bacterial meningitis. That we cannot really prevent them to be admitted. They need to be treated and they need to be in the hospital. But where we could save is not admitting those with viral meningitis. So here is a study we just published looking at cost of those 26,000 patients. What we can first see is that there's an increase in cost if you delay the LP. If you delay the LP, the cultures are going to be negative, and then the physicians are going to say, well, it could have been partially treated bacterial meningitis. They're going to be in the hospital a little longer. We're just going to give them a course of antibiotic therapy. So it's very, very important to do the LP at baseline in the ER as soon as possible, because the sensitivity of the cultures decrease significantly if you start antibiotic therapy. And what's going on is that they're being admitted, 20% of the patients are being admitted, and the LP is being done by radiology in the hospital after the patient has been on ceftriaxone and ampicillin for 24 hours or 48 hours. And that really negates the reason to do the cultures. When you look at different etiologies, let's focus on endovirus. This is the cost for endovirus admission, so it's less. It's $8,000. And the cost incurred before the LP is $3,000. So if you do the LP and you diagnose somebody with endovirus, you could potentially prevent this hospital admission. You can clearly see there's a large advantage, cost benefit if you discharge that patient. So bacterial, again, we're not going to try to discharge those patients, or fungal. In viruses, we can discharge those with meningitis, but those with encephalitis should be admitted for supportive care. Same thing with herpes virus. 80% of our herpes virus are meningitis. They're not encephalitis. And those patients with herpes meningitis could potentially go home, because acyclovir therapy has not been shown to be of any benefit in those with meningitis, only in those with encephalitis. So now talking about novel technology, here we have the film array, the only multiplex PCR that is FDA approved for meningitis and encephalitis. And as you can see, this has a couple of advantages. It can be done in 200 microliters of CSF, only 0.2 cc's of CSF, and you can check for all those etiologies and in 1 hour. So it's fast, it's has a lot of etiologies you can look at, especially some that could go home, like endovirus and parecho, they could go home. Remember VCV, we're only checking that in 1% of our patients right now, so we could pick up more VCV. This is a study that hasn't been published, looking at film array positive cases. And what you can see here, 94% of those film array positive patients are viruses. And this really depicts the epidemiology of meningitis and encephalitis in the U.S. The majority of our patients have viral etiologies, 94. Then 4% are going to be bacterial and 2% are going to be fungal. When we look at the different etiologies, and I was really surprised by this, endovirus is number 1, followed by VCV. 80 cases of endovirus, and the second one is VCV. And we're only checking VCV PCRs in 1% of our patients, at least with aseptic meningitis. We're looking at encephalitis right now. It's a little higher, but still not in the teens. So we're missing treatable etiology. Zoster is a treatable etiology. So we looked at the film array in our study, and what I want, is this is not for you to read it, but just to see what discordants are in the workups of patients. So each blue box is a test that was ordered for each particular patient. You can see that it's all over the board. Some patients get a lot of tests, like patient this one got a lot of tests, this one didn't get even, not a lot of tests. So it really depends on who's taking care of the patient and how much CSF is available. And obviously with this technology we picked up a lot of etiologies because they were not being checked for those etiologies in that study. This is a recent study published in Pediatrics, just looking at endovirus and HSV6 in infants, and you can see that it can also detect positive cases in those without pleocytosis. And it's been well known that in endovirus, you can have no pleocytosis and still have positive PCR, especially in young infants. And that's the film array is also doing that. It's picking up endovirus in those without pleocytosis. This is a study published this year as well, just looking at how the panel is doing in a very large group of samples. They had over 200 patients, and here's the result. Here's what the panel detected. So you can see the true positives, false positive, and the percent agreement. So overall, the percent agreement was good, except for Cryptococcus. You can see here they had 50 cases where they basically missed 24 of them. So there was around 50% were false negative. So for some reason in this study they did not pick up crypto. Okay. And there was also some false positives in Streptococcus pneumoniae, a few cases of false positives. So it's very important to handle the sample well and not contaminate it with the oral flora. This study published at ECMID, looking at the film array in 511 patients. And in this study, they were able to see that they detected more etiologies versus standard of care. So 9.4% were detected versus 5.4% by usual care or standard of care. And they had global concordances of 98, 98, and 98% with viral, bacterial, and mycological, respectively, in this study. So what are the pros and cons? First is rapid, 1 hour, 0.2 cc's, has good diagnostic accuracy, and it really checks for urgent etiologies and etiologies that can help discharge the patient. And is really the only one available right now. It does not check for West Nile, and if you're in the West Nile season, you need to do a serology. It doesn't check for TB or travel-related pathogens. Again, there's false positives with strep pneumo, and there's been false negatives with Cryptococcus neoformans, especially in that study by Dr. Leisman. So what happens if we implement the film array in our hospitals? This is an economic mathematical model. This is not based on patients. It's based on databases and the utility of the film array. What basically shows is that if you use more the film array as an inpatient from 0 to 100, you're basically going to have less cost. And this is in the targeted test scenario. That means you're only testing those with pleocytosis. If you test everybody, the cost benefit is higher. And this is, again, most likely, and this is in pediatric patients, not adults, this is most likely because of the nanovirus that can be detected in those without pleocytosis. So in this economic model, it shows that it can decrease cost if you implement the film array. There's other technologies out there that are not FDA approved, and some that we don't even have studies on or don't know what the panel has. So there's this one called the Multiplex CSF Direct B, and this is only for bacterial meningitis. So this is only going to detect strep pneumo, group B strep, meningococcus, and listeria. And it was compared to 16SR sequencing, culture, and gram stain, and it looks really good in those 4 pathogens. But again, it only detects those 4 bacterial pathogens. It's a little faster, is in 30 minutes instead of 1 hour. There's another one that's in development by Genmark called the CNS Eplex panel, but there are no studies available that I'm aware of. And then there's this TaqMan Array in CNS infection study, where it really detects a lot of more etiologies than the film array. So look at Bartonella, chikungunya, CMV, EBV, HSV1, HSV2, measles, mumps, TB, VCV, mycoplasma, Nipah, meningococcus, dengue, Haemophilus. It's a long list, even amoebas. But the experience is not that much. There only have been 7 patients with CMV, and the TAC didn't detect 2 of them. There was 5 with meningitis. They were all detected. 8 detected by this assay, by 10 by the TAC. So you see that the data is really small right now, but that's another multiplex PCR that's being evaluated right now. And this is another technology that I think could change the outcomes of our patients in the future. It's high throughput PCR, or next generation sequencing, where you basically get this the genetic material from the sample and do a blast analysis where you can corroborate the genomic sequencing of what you find in the sample with the NIH database to tell you what virus, bacteria, fungal, TB pathogen you're looking at with high degree of confidence. So it will tell you it's a 99.8 concordance with an astrovirus. And it can actually detect new pathogens. So it's a new pathogen discovery tool. There's Dr. Wilson from UCSF is currently funded by the NIH to look at this technology in patients nationwide with unknown meningitis and encephalitis. So if anybody has an unknown case and you're struggling at your facility, you can actually contact Dr. Wilson. They're very responsive, and you can send them CSF and even brain tissue. I've sent them both on different patients. The problem is that through research, it takes 2 months to get the results. And obviously, the patient is already either in rehab or who knows where. So it's not, it's for research purposes right now. It's not, but it's another tool that you can develop. In this patient, they had a patient that came in and was having fevers and altered metastasis, seizures, and it was going on for a month. Patient was going downhill, was going to die. It was a young patient. They did next generation sequencing, and they found leptospirosis. They started doxycycline, the patient got better and got discharged. So it's one of those technologies that could potentially be of help when you're against the wall in a very sick patient. And again, Dr. Wilson published this year his experience with chronic meningitis, and he was able to detect 7 etiologies with the next generation sequencing. Taenia solium in 2, crypto in 1, HIV in 1, aspergillus, histo, and candida dubliniensis. This was in an IV drug user that came in with an epidural abscess. So it can detect etiologies when standard of care does not. It has also detected Cache Valley fever, West Nile and renal transplant, balamuthia in a patient, and human Peggy virus. So weird viruses can be detected by this technology. And I'll just finish up with this. This is a very nice technology. The Oxford Nanopore Minion sequencer is that small. It's like this. And it's $1,000, not expensive. You can actually do high throughput sequencing with this device. Each cartridge costs $500, but you can get it for $350. You get several of them. And this is a metagenomic sequence you can do in your lab with just very small device like this, very uncomplicated device. In the future, this is going to be connected to an iPhone. So it's going to be an iPhone with that, and you'll be able to do metagenomic sequencing anywhere, as long as you have Wi-Fi, and you can connect to the database of the NIH. So that's another technology that we're exploring right now. We're very excited. The problem that we've seen so far with this technology is that it picks up contaminants. So you can come up and say, well, you have this bacteria, but it doesn't make any sense clinically. It's probably just a contaminant. It's so sensitive, it'll pick up anything. So that's one of the things. So if it picks up leptospirosis and you give doxy, the patient got better, great. But if it picks up something from the lab, there's nothing to do. It's just contaminant. And with that, I think we'll be taking questions at the end of the second lecture. Thank you very much.